All right, strap in, everyone. Today we're going deep on a topic that's both fascinating and kind of intense: pediatric emergencies.
Yeah, high stakes.
We've got a mountain of sources, textbook stuff, case studies, EMT training materials, even some presentation slides.
Wow, a real mixed
The
bag.
mission: boil it all down to the essential nuggets you need. Walk away feeling like mini experts.
I like that.
And trust me, you'll see why kids are not just small adults. Not even close.
Absolutely not. It's like they're playing by a whole different rule book, anatomically, developmentally, even psychologically.
Okay, so let's jump right into this kids are different thing. The
Mm.
sources really emphasize those anatomical differences, and some of them, honestly, are pretty mind-blowing. Like, you wouldn't think a baby's tongue could be a life or death situation.
You'd be surprised.
Really?
It's almost like imagine trying to squeeze a giant sausage into a shot glass.
Oh, that's a visual I was not prepared for.
That's basically what we're dealing with when it comes to an infant's airway. Their tongue is proportionally massive compared to their mouth, and their airway is shaped more like a funnel.
So that's why choking is so much more common in infants, because their airway is just easily blocked.
Exactly. And it makes things tricky for first responders, too, because if you don't position the head just right during airway management, that big tongue can totally obstruct the airway.
It's not just about knowing the techniques, it's about adapting them to a completely different anatomy.
Precisely. And it's not just the airway. Their bones and soft tissues are still developing, which makes them susceptible to, well, different kinds of injuries.
The sources mention these things called growth plates, areas of active bone formation at the ends of their long bones. So how does that change things when we're talking about injuries?
It's kind of a double-edged sword. On one hand, those growth plates make their bones more flexible, so they might be less likely to break a bone in a situation where an adult would. But that flexibility can actually lead to injuries you wouldn't see in an adult. Oh, okay. I have a feeling this is where it gets really interesting.
Picture this. An adult and a child are both in a car accident. The adult might injure their knee, but the child could fracture their femur, the big thigh bone, simply because of how their body absorbs the impact. Totally different.
Wow. So what looks like a minor injury on the outside could be masking something much more serious internally.
And then there's this crazy thing called a flail chest, where several ribs are broken, detached from the rib cage, causing serious breathing problems.
Yeah, I've heard of that in adults, but it sounds terrifying in a child.
It is. But here's the kicker. Because kids' ribs are so flexible, they can actually have a flail chest without any broken bones.
Wait, seriously? How is that even possible?
I know, right? It blows your mind when you realize how different their bodies respond to trauma. It really underscores why understanding those differences is crucial, absolutely crucial, in an emergency. Okay, so we've established kids are practically a different species anatomically.
Yeah.
But the sources also say their developmental stage plays a huge role in the types of emergencies they're prone to.
Right. Think about it. Toddlers, they're putting everything in their mouths, right?
Yeah.
So choking, poisoning, those are major concerns at that age. Then you have school-aged kids. They're starting to push their limits. Riding bikes, playing sports, more fractures, sprains, concussions. And then, of course, teenagers, the kings and queens of risk-taking. Experimenting with drugs, alcohol, other behaviors that, well, that can lead to emergencies.
So each stage of development, it's like it comes with its own set of built-in risks.
Exactly. And that brings up a really important point. How we communicate with children during an emergency, it has to be tailored to their age and understanding. What works for a teenager isn't going to work for a toddler.
Speaking of which, the source material has this really cool age-by-age guide for communication and what to expect medically at each stage. Maybe we could walk through that. It might help our listeners know how to approach a child in an emergency based on their age.
Sure, let's do it. Let's start with infants, those under a year old. They can't tell us what's wrong, so we rely on those nonverbal cues. Crying, facial expressions, body language. Almost like learning a whole new language.
And medically, we're dealing with fevers, dehydration, those airway issues we talked about.
Yeah.
They just seem so fragile at that age.
They are. Now, jump to toddlers, 1 to 3 years old. They're starting to understand words, but their vocabulary is limited, and they're easily scared. One of the sources actually warns against lying to a preschooler, even if you think it's for their own good.
Why is that?
Apparently, they have incredible memories. They'll remember if you lied, which makes it even harder to gain their trust in future medical encounters. It's all about building that rapport.
That makes sense.
Yeah.
Plus, toddlers are mobile, but not exactly coordinated, so falls are super common at that age. Building trust would be crucial.
Then we hit the preschool years, 3 to 6 years old. Their communication is getting better, but they still thrive on routines and familiarity. So a sudden change, like being in an ambulance, can be really upsetting. The sources suggest distraction techniques, simple explanations, maybe even letting them hold a piece of equipment if it's safe, just to give them that sense of control.
That's a great tip. I can see how that would calm them down. Medically, what are the big things for preschoolers?
This is when we start seeing those respiratory infections, croup, bronchiolitis, because their immune systems are still developing.
Right, croup is that one that causes that awful seal bar cough, right?
Exactly. It sounds just like a Burking seal. And bronchiolitis, that often leads to wheezing because even a little swelling in those tiny airways can make it really hard to breathe.
So we've got infants, toddlers, preschoolers. What about school-age kids, like 6 to 12 years old?
Communication gets a little more straightforward. They can understand explanations, follow instructions. They might even be able to tell you what's wrong.
But I imagine those social dynamics become a bigger factor. Self-conscious about their bodies, worried about what their friends think.
Absolutely. Sensitivity and reassurance are key,
That
especially if they've been injured.
makes sense.
And then finally, we have adolescents, 12 to 18 years old. They can communicate like adults. They often understand complex medical concepts.
But they're still teenagers, emotionally speaking. Might downplay symptoms to seem tough, or get super anxious about things like scarring or long-term effects of an injury.
Right, right. And of course, the risk-taking factor. This is a time of experimentation with drugs, alcohol, potentially unsafe sexual activity, all things that can contribute to those medical emergencies.
So even though they might sound like adults, they're still kids with all the complexities that come with that. Now, I'm picturing myself in a situation where I see a child who might be sick or injured. How do I know if it's serious? Is there like a tool or framework to help?
That's where the Pediatric Assessment Triangle, or PAT, comes in. It's a quick visual assessment tool that helps you prioritize care and determine if you're dealing with something that needs immediate attention.
Okay, I'm intrigued. Tell me more about this PAT. How does it work?
It's like a quick scan, like checking the gauges on your car's dashboard. You're looking at 3 key areas: appearance, work of breathing, and circulation.
So just by looking at a child, I can get a sense of whether something is seriously wrong.
Exactly. Let's start with appearance. You're checking their mental status, like are they alert and interactive or are they listless and unresponsive? Is their muscle tone normal for their age? You know, a baby should be able to hold their head up. A toddler should be able to walk and run.
So like if a normally energetic toddler is suddenly quiet and just staring blankly, that would be a red flag.
Big time. And then there's work of breathing. Are they struggling to breathe? Are they using those accessory muscles in their neck and chest? Any nasal flaring where their nostrils widen with each breath?
One of the training slides mentions grunting sounds. It actually describes it as a noise, as if they were trying to blow up a balloon.
That's a great way to put it. It's all about them trying to force air past whatever's obstructing their airway. And remember, that obstruction could be anything from a foreign object to swelling in the airway from an infliction.
And then there's that classic tripod position, right? Where they're leaning forward with their hands on their knees to help them breathe.
Exactly. All those are signs of respiratory distress, and they tell you the child needs help fast. And then the final piece of the PAT is circulation.
So we're looking at their skin color, right? Making sure they're not pale or mottled. Checking for cyanosis, that bluish tint that means low oxygen levels.
Right. And don't forget capillary refill time. You press on their fingertip for a second, then see how long it takes for the color to return. Should be less than 2 seconds.
So anything longer could mean their blood isn't circulating properly.
Which could be a sign of shock.
So the PAT gives me a quick snapshot of the overall situation. But what if the child seems stable at first, but then their condition starts to go downhill?
That's why constant reassessment is so important, especially with kids. Their bodies are incredibly resilient, but they can also crash quickly. It's like they're putting up a brave front, but behind the scenes, their body is struggling to keep up.
Okay, so let's say I've used the PATT to get an initial impression. I've considered the child's age and developmental stage. I've started communicating with them and their caregiver. What's next? How do I figure out what's actually wrong and what needs to be done?
Well, that's where knowing the common pediatric emergencies comes in. And one of the big ones, as you might have guessed from our anatomy discussion, is respiratory distress or failure.
Right, because we know kids have those smaller, more easily obstructed airways. So aside from the signs we already talked about in the PAT, are there any other red flags for a breathing problem?
Well, you mentioned croup earlier with that characteristic barking cough, Epiglottitis is another one to be aware of, although it's less common now because of vaccinations.
Epiglottitis, that's where the epiglottis, that little flap of tissue that protects the airway, gets inflamed and swollen, right?
Exactly, and that swelling can completely block the airway, which is why it can be so dangerous. Then you have bronchiolitis. It's a viral infection that affects the bronchioles, those tiny airways in the lungs.
And that's the one that often causes wheezing.
Right. And kids with bronchiolitis often have a lot of mucus, which can further obstruct their breathing. So suctioning might be necessary. Now, shifting gears a bit, another major emergency we need to talk about is shock. And this is where those physiological differences in children really come into play.
The sources emphasize that kids can compensate for blood loss for a surprisingly long time. So how do we know if a child is going into shock if they're not showing the typical signs?
That's the challenge. It's like their body is trying to trick you. Their blood pressure might be normal even when they're losing a significant amount of blood.
So what should we be looking for?
Subtle changes. Their heart rate might be a little faster than normal. Their skin might be cool and clammy. They might be a little more irritable or withdrawn. Capillary refill time, like we discussed earlier, can be a really good indicator.
So it's about looking at the whole picture, not just relying on one single sign.
Exactly. Now, aside from respiratory distress and shock, seizures are another big one that can be really scary for parents and caregivers.
I know some parents whose baby had seizures, and they said it was the most terrifying experience of their lives. What are some things we should know about seizures in kids?
Well, first of all, it's important to remember that most seizures are not serious. They're often triggered by a high fever, especially in young children, and they usually stop on their own.
The sources mention something called febrile seizures. I think it's what you're describing.
Right. Febrile seizures are pretty common, and they usually don't have any long-term consequences, but that doesn't make them any less scary to witness.
So how do we know when a seizure is an emergency?
If it lasts longer than 5 minutes, or if the child has multiple seizures in a row, that's when you need to call for help. Now, we've talked about problems with breathing, problems with circulation, problems with the brain. But what about emergencies that involve the whole body?
You mean trauma, like from a fall or a car accident?
Exactly. And remember all that stuff we talked about earlier, how kids' bodies are different from adults? Well, that all comes into play big time when we're talking about trauma.
One of the sources mentioned that a child might fracture a bone in a car accident where an adult would only have a sprain.
That's because their ligaments, the tissues that connect bones to each other, are actually stronger than their bones at that age.
So it's almost like their bones are the weak link.
In a way, yes. And because their heads are proportionally larger than adults, they're also more prone to head and neck injuries.
Plus, their internal organs are more exposed and less protected by muscle and fat, so they're more vulnerable to abdominal trauma.
Exactly. So even if a child doesn't have any obvious external injuries after a fall or an accident, you always have to consider the possibility of internal damage. Now, we've covered a lot of different emergency scenarios, but there's one more we need to talk about that's especially relevant for anyone who's ever been around water.
You mean drowning?
Yes.
Yeah.
And this is where the psychological differences between children and adults really hit home. Children, especially young ones, don't have the same understanding of danger as we do. They might overestimate their swimming abilities or simply not realize how quickly they can get into trouble.
It's heartbreaking because it only takes a few minutes of oxygen deprivation for drowning to cause serious brain damage.
Exactly. And in addition to the obvious airway and breathing management, we also have to consider the possibility of a neck injury, especially if they dove into shallow water.
So even if a child seems okay after being pulled from the water, it's crucial to get them checked out by a medical professional.
Absolutely. Now, I know this is a lot to process. We've covered a lot of ground, and it can feel overwhelming. But before we move on, are there any particular scenarios or conditions you want to revisit or anything you'd like me to clarify?
We've covered a ton in this deep dive into pediatric emergencies. Anatomical quirks, developmental stages, all sorts of scary scenarios like shock, seizures, drowning. But before we wrap up, there's one more area the sources touch on that feels, well, pretty sensitive.
You're talking about those situations where it's not just a physical injury or illness, but something like child abuse or neglect, SIDs, or even those apparent life-threatening events where a baby suddenly stops breathing.
Yeah, exactly. Tough scenarios to think about, both emotionally and in terms of how we respond. The sources seem to stress that as bystanders or even first responders, we're not expected to be diagnosticians. But there are things we should be aware of.
Right. With child abuse, for example, it's not our job to prove anything, but we do have a responsibility to recognize potential signs and report our concerns to the right people.
The sources actually give a helpful mnemonic to remember those signs. It spells out CHILDABUSE.
Yeah, I've heard of that one. So that stands for consistency of the injury with the child's developmental level, history incompatible with the injury, inappropriate parental behavior, lack of supervision, delay in seeking care. Then ABUSE is affect, bruises, unusual injury patterns, story changes, and environmental clues.
Wow, a lot to keep in mind, but I see how each of those could be a red flag.
And then there's SID, sudden infant death syndrome, obviously just a devastating situation, and our role is mainly about supporting that grieving family.
The sources talk about the importance of scene assessment, not missing signs of foul play, but also just being sensitive to the family's emotional state.
Absolutely. Providing reassurance, explaining things clearly, answering their questions honestly, even though it's a difficult conversation to have.
Definitely.
And then there are those apparent life-threatening events, or LLTs. Basically, when a baby suddenly stops breathing or turns blue, but then recovers on their own.
Right, and those are also called BRUEs now, brief resolved unexplained events.
Right. Those can be terrifying for parents, but it's important to emphasize that most infants who experience a BRUE, they don't have a serious underlying medical condition.
Still, the sources say any baby who's had a BRUE needs to go to the hospital for a full evaluation, just to be safe.
Exactly. Better safe than sorry. So you've had a crash course now in pediatric emergencies. We've explored why kids are unique, how to assess them quickly with that PAT, and we delved into a whole range of scenarios. Breathing problems, trauma, those really sensitive situations like child abuse and SIDs.
You're now armed with knowledge. But remember, this is just the beginning. The best way to get truly confident in dealing with these situations, keep learning, keep practicing your skills.
And don't underestimate your instincts. If you see a child in distress and something feels off, trust your gut and get medical help.
Absolutely. It's always better to err on the side of caution when it comes to kids. So, as you go forward with all this new knowledge, here's a final thought-provoking question. Imagine you're at the park. You see a child fall from the monkey bars. How would you approach that situation? What would your initial assessment look like? What factors would you consider based on the child's age, how they fell, and how distressed they seem? Keep those questions in mind, stay curious, and never stop learning. Thanks for joining us on this deep dive into the fascinating and sometimes challenging world of pediatric emergencies.